Hello.
Good evening.
Good evening, Dr. Stephen. How are you?
Thanks, I'm fine, Dr. Bal. How are you?
Good.
May I
All
ask-
good.
You're also based out of India, right?
Yes, yes. In the capital of India, New Delhi.
I've been there 1.5 years ago, 2 years ago, maybe, shortly before the COVID outbreak. 3 years then, shortly before the COVID outbreak, basically.
Good morning, everybody.
Good morning, good morning, good evening from
Good
India.
morning.
Just checking my screen if it shares well. Just checking. Yeah, it's fine.
Looks good.
So, Darshana, can you help me how to go back?
Usually when you're going upwards, you should have there somewhere that you can stop the presentation, a red
Yeah.
button. But it's not there.
Pause share. I'll log out and come in. Yeah.
Good evening.
Hi, good
Hello.
evening.
Good evening. Dear IT team, could you also bring Andrew Gaia in the session? Because he's already online.
We informed him. He will join as a faculty.
Good evening, Stephen.
Hello, good evening, Dr. Nitish. Nice to meet you.
Nice to meet you. The team at the TAR is very scared of you. I'm telling you that already.
Okay.
They warned me to make my presentation in time and send it to you. They said, you can mess with us, don't mess around with Stephen.
No, I'm actually a very nice guy.
Okay, waiting to meet you there.
Good morning, everybody. This is Dr. Masudi.
Hi, Dr. Masudi. Good evening.
Good evening.
Good
6:30
evening.
a.m.
Yeah, good morning then.
Good evening.
Yeah.
Hi, Dr. Behel. Good evening.
Hi, Dr. Rodke.
Santi joined in.
Yeah. Only Dr. Gaia is somehow stuck. I don't know why he's not brought on board.
He's working on it, Stefan. In a minute, I think we can begin the session.
Great.
Dr. Fazat has already joined.
Hello. Hello, Dr. Gaia.
Fine.
Even if you are called Dr. Darshana Patil, I'm sorry for that.
No worries. I think I had the attendee link rather than the presenter link. So
Sorry for
sorted
that.
now.
So I believe we are all online. Maybe we wait another minute. We have at the moment 40 participants in the room.
Hi, Andy, Nitesha.
Hey, look, nice to see you.
Nice to see you. Nice to see you.
Been a long time.
A very long time. I'm guessing 10 years and few months. That's how long I've been in India.
Yes. Wow.
I'll catch up with you. I'll be in England in a few months. I'll catch up with you there.
And I'm actually giving this presentation from Estro in Vienna at the moment. So
Oh, right. Okay.
completely global.
Truly. Okay. I'll be
So,
mic off.
I believe we can start now. So thank you everybody that you joined today. Our international symposium on precision oncology. So good morning, good afternoon, and good evening to all our participants from all over the world. I'm honored that we have today global experts in the field of oncology from the US, UK, and India. This is why we span half of the globe. And basically the whole daytime. And we will discuss today the utility of cutting-edge molecular genomics and the role of precision oncology in the management of solid organ malignancies. I am Dr. Stefan Schuster from Data Cancer Genetics. I'm responsible for the European business, basically, and some other countries. Before we start with our presenters, let me give you just one slide of introduction about Data Cancer Genetics so that you are all aware who we are and where we are based. Just a second, I will share my screen. Everybody should see it now. So here you can see our headquarters based in Nashik near Mumbai. For all those who are not from India or Bangladesh, Nashik is a small town with several million inhabitants north of Mumbai. The Data Cancer Genetics Group is based currently in India, UK, has in Germany offices where I am at the moment, and also a lab meanwhile in the US. We have several accreditations in all our laboratories where we're dealing especially with screening, early cancer diagnostics of solid tumors, and therapy management and monitoring of solid tumors. So we are basically a company focused on oncology diagnostics. We were founded in 2013 and currently we are 250 people. So that's basically it from my side, because now I believe everybody wants to know that what our participants can tell us. And I want to start first with Dr. Farzad Masoudi, just maybe 2 sentences how we move forward now. So everybody has now 15 minutes to talk. Before the talk, I will shortly give an introduction about the respective speaker. And after 15 minutes, we have a 5-minute Q&A session. Everybody can ask his questions in the F&A part, and I will ask the questions and present them to all of the audience afterwards, so in the 5 minutes. So, Dr. Farzad Masoudi, it's a pleasure to have you here today. Dr. Farzad Masoudi did his undergraduate studies in biology at the University of California. Beautiful place, I've been there twice. He received his medical degree from Georgetown University School of Medicine. He's a certified neurosurgeon and affiliated with multiple hospitals, including Memorial Care Saddleback Medical Center and Providence Mission Hospital. He has his primary specialty in brain and spine surgery. He holds the position of medical director of the Neuroscience and Spine Institute at Mission Hospital Regional Medical Center in Mission Viejo, California. He's the CEO of the Masoudi Foundation, and he has been practicing for more than 15 years and is president of Orange County Neurosurgical Associates in Laguna Hills, California. Today, he will speak about new approaches in glioma diagnosis. Dr. Masoudi, the stage is yours. Please start sharing your screen. Thank you.
Good evening. It's a privilege and an honor to be here at this presentation. At the moment, I have a hard time sharing my screen. Is there any way you can?
No problem. I will share my screen and you just give me a ping whenever you want to have the next slide. Is this okay for you?
Okay.
I hope this is the right presentation.
Yes.
Okay, great.
Yes. So it's an honor and privilege to be here. I wanted to use this opportunity this morning to speak about one of the challenges we have in the neurosurgical diagnosis and treatment of brain tumors. Patients who present with space-occupying lesions in the brain that exhibit MRI characteristics of a glioma, a malignancy, oftentimes have to undergo an invasive brain biopsy to establish the diagnosis. And this procedure has its associated potential complications in terms of potential mortality and morbidity. And at times we're dealing with lesions that are deep-seated and are either operatively speaking inaccessible or because of their proximity to surrounding critical structures, biopsying them would pose significant dangers to the patient intraoperatively and postoperatively. If I can have the next slide, please. So the diagnosis of brain malignancies has traditionally been challenging. It has been associated with a significant need for utilization of resources as far as operative procedures and post-operative care of the patients and the need for having trained staff. So this is something that conventionally speaking has been a very labor-intensive, laborious process to actually get histopathological specimens in front of the pathologist to make the definitive diagnosis of a glioma. Next. Two-thirds of the brain tumors turn out to be benign. And of course, the confirmation of the benign nature of the tumor and malignant status of the tumor is the challenge that we're dealing with. And we have been looking for less invasive and equally accurate and specific methodologies to establish the diagnosis of brain tumors aside and above and beyond the conventional biopsies. Next, please. So I'm excited to have the opportunity to speak about a revolutionary and transformative method of performing liquid biopsies by analyzing the peripheral blood of patients who are suspected of having brain tumors. We know that brain tumors are found in the peripheral general circulation by the virtue of the fact that there is local breakdown in the blood-brain barrier, and brain tumors do find their way into the circulation and into blood. And really, the question has always been through precision-guided medical techniques and a particular laboratory set of skills, can we identify and isolate and analyze these tumor cells that have found their way into the circulation. Next, please. So the innovative platform that Datar Genetics has developed is really a proprietary process in which a medium has been created that really promotes paradoxical cytotoxicity with regards to normal cells and cancerous cells. In this medium, the cancerous cells are apoptosis resistant, and through the process of being exposed to this very specific medium for a period of 5 days, they actually survive their stay, whereas all the other normal cells, nucleated cells, undergo functional apoptosis as their DNA is programmed to do so. And really, at the end of this process, you end up with cancerous apoptotic resistant cells that can then undergo further growth and immunocytochemical analysis and configuration and characterization. Next. So this is really the trinetra glio principle, where we then take the cells that have not undergone apoptosis and subject them to a battery of immunocytochemical analyses and tests to identify their glial origin, and then subject them to an encyclopedic analysis of what I seem to have lost contact with. Hello?
I can still hear you and I can still see you. So, Dr. Fasad?
Yes.
Okay, we can still hear you and see you.
Okay, so because I've sort of lost connection on this end, so I'm going to go ahead and just go off of my notes here. So once the glial cells are isolated and have undergone immunocytochemical analysis, the trinetra process then allows us to establish their identity as cancer cells definitively, and then apply really an encyclopedic knowledge of what we know about this particular cancerous cell type and its sensitivity to a variety of different chemotherapeutic agents. So it's becomes a non-invasive peripheral blood test that establishes the cancerous nature of the glioma cells that are circulating in the blood, and then it subsequently gives us a track and a path towards treatment. The clinical trials, if we can go to the next slide, because I've kind of lost the slide set on my end. The clinical trials that have studied the concordance, the specificity, and the sensitivity of this test were largely done in the Imperial College in London under the supervision of Dr. Kevin O'Neill, the consultant neurosurgeon, chairman of the Brain Tumor Research Campaign in that institution. And the patients who were enrolled in this study with space-occupying intracranial lesions who underwent peripheral blood tests, these studies demonstrated an amazing rate of concordance and specificity and accuracy and sensitivity of 100% between the histopathological specimens that were proven to be glial malignancies and peripheral blood tests. So this really has been one of the huge milestones in the development of precision-guided peripheral blood tests for establishment of gliomas and establishment of the cancer diagnosis. So one can imagine the advantages of this way of diagnosing are far-reaching and transformative. The otherwise potentially dangerous and high-risk brain biopsies can now be replaced with safe, accurate, specific, and sensitive blood tests to really give us the same information and guide our subsequent treatments for our patients here in the United States and across the world. I'm very excited to be part of this. We are going to take this to the next level, and here in the United States, we're planning on launching a study of 300 patients who will undergo a similar process of correlating the histopathological findings after brain biopsies with their peripheral blood testing to further establish the reliability and sensitivity and specificity of the peripheral blood test and liquid biopsy as a transformative way of substituting for more invasive, dangerous brain biopsies. And thank you very much. And that was the end.
Dr. Masudi. I hope it was still it was a very interesting talk, because especially in gliomas, there was still always the issue, can we really detect those cells coming from the CNS? We have already one question. The question is, how early in the natural evolution of the blood of the brain cancer is it possible to detect the cancer cells in the blood? Do we have any idea about this?
Yes, the amazing thing about the sensitivity and specificity of this TriNetra platform and laboratory test is that when the patients are asymptomatic and they exhibit minimal evidence of presence of the tumor in their MRI studies in the very early stages and asymptomatic stages of their disease progression, we can actually establish the diagnosis of a malignancy in them, which gives us potentially a huge head start in going after the lesion on a number of different planes and levels, including radiation and chemotherapy, as well as potential surgical intervention.
Thank you very much. I think this quite answered the question. Maybe, yeah, Dr. Nitish, you have directly a question.
Well, it was really a fantastic talk, Dr. Masudi. Principally, I find it very difficult to imagine that somebody has a mass in the brain, which is high perfusion, high contrast, diffusion restricted. We will not operate on that patient. So I guess that will happen anyway. I'm really questioning that the role of this technology would be far more when a year and a half later we debate almost in every patient the radiation necrosis versus a disease recurrence. So is there a study group that we are trying to study in that respect, rather than upfront, now that we've proven that the ability of the test is true?
That's an excellent point, excellent question. Yes, sometimes patients present with space-occupying lesions that are operatively approachable and surgically resectable. They present with mass effect associated with the tumor and surrounding vasogenic edema. And in those instances, surgical intervention is definitely the first-line treatment, and you establish the diagnosis along the way. Upfront, we were talking about patients who perhaps have a potential set of risk factors for development of CNS malignancies, or have deep-seated, surgically inaccessible tumors that are not associated with mass effect, and biopsying them would pose a significant potential danger of hemorrhage or neurological deficits. But the strength of this platform, as you alluded to, really is along the way as well. When you have initially treated patients and established a diagnosis, and a year or two later, you're wondering if the tumor has recurred or if this is radiation necrosis or a mixture of two. And as we know, tumors change their sensitivities to a variety of different chemotherapeutic agents as they evolve or devolve, for that matter. So this platform, this proprietary platform, is not only effective in establishing the diagnosis of CNS malignancy upfront, but it also can guide our treatment of patients down the road as they develop imaging characteristics that may be construed as recurrent tumor or radiation necrosis. And then it kind of gives us a good idea of what and how to treat the recurrent tumor based on its sensitivities to a variety of different treatment options. So it is a tool along the way as we're taking care of the patients, not just from the onset, but throughout the care of the patient in the months and years to follow.
And has it been tested in that setting?
In the brain arena, it has not been tested in that setting, and that's something that we look forward to establishing its concordance and sensitivity and specificity as time goes on.
Thank you.
One last question, maybe a short question from Professor Hazanzad. Sorry for that. If it can be also used in asymptomatic cases with a family history of glioblastoma?
The short answer is yes. There are some nuanced caveats to that answer in terms of how do we identify these patients and how do we approach the subject matter with them. But in patients with risk factors such as familial disease or known other genetic mutations that predispose them to development of CNS malignancies, this can be used in asymptomatic stages of the disease presentation.
Thank you very much, Dr. Masudi. I think there is still a lot to come in this field, and I think we have numerous possibilities how we can use this, especially in the future with more data coming in. I want now to present our second speaker, Dr. Nitesh Rottagi. He received his MBBS from University College of Medical Science, completed his CCT in 2009. He was well trained in medical oncology, palliative medicine, and teenage young adults cancers in UK. Being a medical oncologist with more than 21 years of expertise, he's a senior director of the medical oncology at the Fortis Memorial Research Institute, Gurugram, India. He's a fellow of the Royal College of Physicians, UK, Edinburgh, as well as a Royal Society of Medicine. He also worked at prestigious London Oncology Clinic, Harley Street, London, leading the team of breast medical oncology at the Mid Yorkshire NHA Trust affiliate affiliated to Leeds teaching hospitals. Leading with his interest quality of life, bringing about a new dimension to the management of chemotherapy-related toxicity amongst cancer patients. He will talk today about precision oncology in relation to lung cancer. Dr. Nitesh, it's up to you.
Thank you. That was a bit of a struggle. It was too long. Thank you very much. Really an honor to be here. And it will be very difficult following Prof. Masudi's shoes. But lung cancer has been the poster boy of precision oncology. And I've been doing lung cancer. I feel very proud that it led the way. Now, remember, this was a difficult cancer. So it becomes even more important. This is a wonderful, beautiful hospital on the suburb of Delhi called Gurugram, and the left side is a logo which we have designed, which basically talks about cancer attacks every circle, and we combine all the strength to fight it. And today is an example of that. We started with brain, we're going on to the lung. And this is my favorite slide, which is the only thing constant in the world is change. And we've seen that in cancer, especially with molecular and precision oncology, than in anything else in medicine. But why is it important to talk about lung cancer? Because lung cancer remains one of the largest incidents of cancer in the world, along with one of the largest mortality, including in India, where at least what data is available, and we know that's much less, there are close to 80,000 patients per year, and this number is very rapidly escalating. We remain to, the cancer remains to have extremely poor mortality, and that's evidenced by the fact that even as you reach stage 2, half the patient will be lost at 5 years to the cancer. And this is unique to lung cancer. It is a devastating cancer as we know it today. But life changed. It went from 1970s, when you can see that the base survival was in months enough that people did not treat metastatic lung cancer at all. In fact, lung cancer stage 3 was also left to patients' best supportive care. And then came in better surgery, better radiation, certainly better chemotherapy with slight changes in survival curves. But then finally, in 2000, early 2000, came in targeted therapy. And the poster boy of that was EGFR, where we found a surface receptor, blocked it, and we suddenly started seeing survivals going into years together. The targeted therapy world got better in the late 2000s, and then came in the immunotherapy, which we know is again made a big change, to the point where we have gone from saying there's no treatment to now at least half our patients are not needing chemotherapy to be treated, and their survival and quality of life have all improved. So what is targeted therapy? Very briefly, we've gone from one drug fits all, which was chemotherapy, to one drug fits majority. So for example, EGFR, where 25 to 30% patients will benefit from the drug, to actually talking about one drug, a precision oncology tumor profile, breaking the DNA into very specific abnormalities and mutations, and seeing if that patient needs a combination of therapy. And in fact, as the disease evolves, can we change the therapy as well? And that is not only now fiction anymore, it's a reality. We run this in our clinic on a daily basis. We do repeated liquid and solid tissue biopsies. We do pick up the changes in targets and we treat. And very quick affirmation of that is that between 2015 to 2025, which is around the corner, the number of targets and therapies is going to rapidly increase. And we are already seeing that. We've gone from just EGFR and ALK to ROS1, RET, MET, BRAF, certainly ALK. We are finding solutions for KRAS finally. The NTRK has a big effect. IDH is coming around, and TMB, MSI, PDL1. And I'm sure there's a lot more to come. This is only going to get busier with time. This was a good study which shows that when you really mass targeted therapy, survival is better in all comers. And this is only going to get better. And based on these kind of studies, there's a clear recommendation of doing lung cancer panel for all patients in lung molecular panels in all patients of lung cancer, even squamous, now even small cell. And if you don't have tissue, in fact, the guidance is now suggesting liquid biopsy as well as combination of solid liquid together which may have in fact a better pickup, and especially when you pick up a change if the patient's cancer evolves. This is an example of a 56-year-old female who was otherwise well, presented cough and breathlessness. And we did her a PET CT which showed a lung tumor with liver, bone, and asymptomatic brain mets. The average survival of this patient 15 years ago was 6 months, and they were often not treated. We did a biopsy, showed EGFR negative, ALK negative, which was the standard way of testing at that moment. However, while we started chemotherapy, we sent the patient for a comprehensive genomic profiling on a better testing sheet, on a better testing platform. And this is important because your test has to be on the right platform, otherwise you miss patients, and we had missed a ROS1 in this patient. What happened next is evident. That time we had only crizotinib, which we started. She managed good 1.5 years, but then had a slight headache. We were all vigil. We did the test biopsy again, tested again. She was still ROS1 positive. We gave her serotinib. That was the only drug that time. Now there are clearly better agents available. She managed 3 more years, and 4.5 years from when she was diagnosed with a lung cancer with brain and liver mets was something we had not heard of before. And this was a while ago. This number is getting better. This is another example. We recently published this poster at BTOG, which concluded only a month ago, where we had a patient who in fact failed, who we could not pick up any, I think I am slightly short. So we could not pick up a molecular pattern abnormality there. So we gave him chemo and immunotherapy after his recurrence. At progression, I was not convinced because he was a non-smoker. So we did a repeat of testing on comprehensive genomic profiling, broad panel, and we were surprised when a patient who had BRAF, which was not targetable, we found a MET. And we can see how giving him capmatinib, a targeted MET mutation, changed the PET scan even within 3 months, and now it's 6 months and he's still doing well. But the importance of this is that this patient, if you look at his history, had failed all other therapies from chemotherapy, multiple lines to immunotherapy. And these patients typically have survival in weeks and months. And he went from coughing and breathless to now 6 months later, still disease-free. And that is the importance of targeted therapy. And that is the importance of having a good panel and a solid liquid, I must say, because we found this on liquid biopsy. Immunotherapies is changing fast. Note, this patient is 76 and has a disease full of her body, full of metastatic disease from bone, liver, and lung. And we tested this patient EGFR, ALK, ROS1 negative, PD-L1 was 80%, TMB was high, MSI was low, all of it suggesting immunotherapy could be given. The response rates of standard therapies are 30 to 40%, and survival was 5 to 6 months. Now the survival is up to a year and getting better, even in elderly population. This was the keynote 189 that set the stage for immunotherapy. And even in patient more than 50%, you can see a clear separation of curve. And this patient, as you would have imagined, after 6 cycles, had resolution of bone pain and disease virtually disappear on a PET scan. This is single agent immunotherapy. This is 76 years old. This patient had some toxicity, mainly fatigue, asymptomatic hypothyroidism, which was corrected, and continued to do well for a period of 2 years when he stopped and is still doing well a year later. But that opens the gate for a lot more new targets, immuno and non-immunotherapy. This is the whole list, which is only getting bigger in terms of approval, and the list for what is being looked at is even bigger. We'll discuss quickly 4. TROP2 is one of my favorites because this was a breast cancer protein, and we are seeing how this transmembrane protein is extremely important in some non-small cell lung cancers, especially squamous, which are difficult to treat, as well as adenocarcinomas. The TROP2 positive patients have poor survival rates. And so it is very imperative that we find something for this. And the antibody drug conjugate, a specialized way of delivering chemotherapy, mainly in the mitotic tumors which have TROP2, have clearly shown an advantage in breast cancer. And now in lung cancer, you can see the trials are ongoing, from tropion to the other 3-4 drugs, including the saxatumab govitecan, which is already approved in triple negative breast cancer. And we looked at others as well. So this was the the standard of care docetaxel versus that of DXD clinical trial, which primary endpoint we are awaiting for. And Evoke-01 was for sacituzumab govitecan. But I do think that these drugs have been useful in other tumors. In high mitotic tumors, we will see something here. On the immunotherapy front, there's CD73, which is very interesting. It is believed to play a key role in mediating inhibitory function of the B and T cells. And CD73 is involved with inhibition of T cell receptor activation, which is a very critical method by which the body actually fights cancer and is disabled by the cancer cell to actually enable it to grow faster. In the preclinical models, when CD73 was made to be lacking, it increased anti-tumor immunity and showed decrease in carcinogenesis. And I am looking forward for the results of oleclumumab, which is a fully human IgG monoclonal antibody targeting CD73. This is COAST, which is the control, which is testing monalizumab with durvalumab and oleclumumab, looking at the different ways of targeting the same immune system. And it showed some initial benefit, but that was phase 1. HER2 is a well-known protein in breast cancer, a well-known protein now in biliary tract cancer, and we are clearly seeing some signals in non-small cell lung cancer, which is very targetable. With standard Herceptin, no, not at all, because this is often mutation. This is not amplification, but you can use that mutation to deliver better antibody drug conjugate with trastuzumab deruxtecan, which is clearly shown, DSA201, which is clearly shown to give a strong payload of chemotherapy in HER2 targeted cells with a great effect in almost all tumor types, as well as in lung. The Destiny-04 study design for lung cancer, where lung cancer was included, was comparing it to immunotherapy and chemotherapy, and the results will be open soon. Last but not the least is TIGIT. This is very interesting. Immunoglobulin superfamily receptors expressed in activated T cells, natural killer cells, T regulator cells. And so all of the immune system is using TIGIT at some level. And negative regulatory function is a part of complex web of ligands and receptors. If it's often co-expressed with PD-1, and that's why a lot of the study went along with atezolizumab and evaluated as an immune co-inhibitory target to increase the anti-tumor response to overcome the resistance. You can see the amount of clinical trials that are happening with tiraglobulumab. Oof, that's a difficult word to pronounce. And we're clearly going to see some very interesting data there. So while I don't have results for all this, it is very interesting how we've seen the targeted therapy world and the immunotherapy world change the world of lung cancer from not being treatable to 50% patients who have some level of targeted immunotherapy. That world is changing fast, even with better application of the same receptors. But what I tried to show very briefly is we'll have a lot more coming. So we do need to get very up to date with that. But most importantly, we need to get up to date with a better test that can pick up these very mutations. I go back to saying the only thing changed in the world is constant. Thank you.
Wow, that was quite impressive. Dr. Nitesh, we have already the first questions.
Yes.
Somebody is asking just some inputs from you on why does some patients with EGFR exon 19 deletion progress on osimertinib within 3 to 4 months? Do you have a comment?
So I think this is very interesting. We have looked at, remember my diagram where we said chemotherapy, everybody, EGFR 25% seemed like a magic number, but that is not really true. Our populations, just like a bell-shaped curve, are extremely divisive. There's a 2 standard deviation, the middle of the bell-shaped curve, which they will do well, but there are some which will do much better. They'll go into years of control, some which will do very badly. And these are the patients who have a second mutation, who may have a mutation downstream, for example, KRAS or PIK3, who may actually have multiclonal disease, a EGFR positive mutation and EGFR negative, although most driver targetable mutations are mostly uniclonal, but there's always a separate clone. If a patient has progressed in 3 months, I would look for a couple of things. I would look for smoker or non-smokers. Smokers do tend to have more mutations. And I will look for a repeat liquid or solid biopsy to see if there's a second mutation which can be targeted, just like the MET in our patient that I showed with the BRAF and many others which are coming to light. So I think that's what I think. This patient possibly has a second mutation which we haven't uncovered yet. A better panel will help.
We have already a second question. Are you getting your genetic mutation information from tumor biopsies or peripheral blood tests?
All right, very interesting. If cost was not a concern, I would love both. And I'll say that again, I would love both. When we have started doing more and more liquid biopsies, we are finding that doing both has the highest chance of picking up a targetable driver mutation, a matchable mutation. And not only that, do remember the liquid biopsy also helps you to follow that patient up and understand when to change therapy early. So we have had all these EGFR with MET, ALK patients who fail. But I do accept that by itself, the liquid biopsy may have lesser ability to pick up than solid tissue. At least that's what we understand so far. So if I had to choose one, I would choose solid, at least to begin with. I would use liquid to follow up. If I had option for both, I would do both on day one and only liquid biopsy to follow up.
Thank you very much. One question from my side. You said lung cancer is at the moment the poster boy. What do you think? Can some of those principles be applied also to other cancers soon, or do we still have to wait? Just an example. Dr. Gaia will soon speak about pancreatic cancer, but the guideline in Germany was updated only 1 year ago. Until then, it wasn't updated for 12 years. So what's your guess on that?
I think lung cancer will remain to be poster boy because it's that much discovery is so important. But lung cancer has taught molecular oncology to all other cancers. We now started saying biliary tract cancer is the new lung cancer or triple negative breast cancer is the new cancer of new lung cancer. I do think it will come everywhere, but I think tumors are incredibly different. And we must not forget that lung cancer is now of 5 types, just like breast cancer is now of 7 types. And brain tumor, we are learning, is of 3 types. So, we must differentiate tumor not based on location alone, but based on molecular subtypes. And I think that's what we're learning from lung cancer as well. I think we will become tumor agnostic very soon. And I do think that lung cancer, therefore, will not remain a poster boy for life.
Maybe also one last question, because always when I speak, especially with oncologists that are in the periphery in a smaller practice, not at the university hospital, but they very often say they fear to combine new therapies, independent if they're what kind of therapies, with normal common chemotherapies. What's your stake on that?
Yeah, we have struggled with that. We continue to struggle with that. And I can only accept that this is a very difficult area. I don't think we have answers. But every time we found a solution and that worked, it was out of a lot of discussion with molecular boards. You must have a molecular oncologist, biologist on that. You must have a clinical oncologist of that. You must have a pharmaco-oncologist on that. When these 3 people sit down together and they start looking at interactions, believe you me, altering the dose based on combination pharmacokinetics is possible, but it does require the tumor board, otherwise not.
Thank you very much for those insights, Dr. Nitish. It was really fascinating. Just a small announcement. Now we will start. The next speaker will be Dr. Andrew Gaia, and we will change a little bit the regime. Dr. Ankobal, if you could talk directly after Dr. Gaia, that would be perfect. And Dr. Svanti will be.
I will. Sure.
Thank you very much. So, Dr. Gaia, he qualified his medical studies from St. George's, University of London, but trained in clinical oncology at Imperial College and St. Bartholomew's Hospital. He is a clinical oncologist at the Cromwell Hospital at London Clinic London, treating all subtypes of GI cancers. He specializes in multimodality therapy, combining systemic therapies with radiotherapy, local ablative therapies, and personal genomics to achieve a unique personalized treatment plan for every patient. He's member in a lot of societies, among them ASCO, ASTRO, Royal Society of Medicine, Fellow Royal College of Radiologists, and he has served as a consultant on clinical oncologist at Guy's and St. Thomas Hospital from 2006 till 2020. And today he will update us on advances in pancreatic cancer. Thank you very much. Dr. Gaia, it's yours.
Thank you very much, Stefan. I hope you can all see this. Thank you for inviting me. And pancreatic cancer, as you know, is a huge challenge. It's a huge challenge to treat. It's a huge challenge to get through it in 15 minutes, but I will do my best. This is a summary of what I'm going to talk about. But we don't have the numbers of lung cancer. It's generally 6 or 7% of the cancer burden is pancreatic cancer, but it's a completely different story when we look at morbidity and mortality, because it's the 4th largest cause of death by cancer in Europe. The median survival, despite all the advances we're making in therapy, is still around about 5 months, and the 5-year survival is less than 5%. So we have a lot of work to do to make this Nitesh's next poster boy. So just very quickly going through the standard for care, as everyone knows, in the first line setting is FOLFIRINOX or gemabraxane, based on these trials, PRODIGE 4 and IMPACT. And then in the second line setting, you can switch around. So those that have had FOLFIRINOX can have gemabraxane, but we also have this new agent, liposomal irinotecan or Onivyde, which is combined with 5-FU as per the Napoli-1 study. So there is now another useful combination, and many patients with pancreatic cancer, if they are fit enough for third line treatment, which is not many, but if they're fit enough for third line, then they have this option as well. So looking at personal genomics and targeted therapies, a bit hit and miss in pancreatic cancer. So just going through the history here, erlotinib, oral erlotinib, there was sort of a vogue for that about 10 years ago, but really the results were very, very disappointing. It was essentially hard to replicate these results, and it's fallen out of favor, as have the sort of colorectal type biologicals such as cetuximab and bevacizumab. These were all essentially negative trials in pancreatic cancer. There were no improvements in median overall survival, and these drugs are not used in routine clinical practice today. So looking at the genomics, well, here are some of the germline syndromes that will increase risk of pancreatic cancer. We see a few of these patients, but the majority are spontaneous due to somatic mutations. We have especially Lynch syndrome, which may confer sensitivity to immunotherapy agents. And you've got as well ataxia telangiectasia with ATM mutation, and the BRCA mutations as well, which can confer sensitivity to PARP inhibitors. And I'll show some of the data for that now. So here are the top 20. The top 20 driving mutations in pancreatic cancer. By far the winner here is KRAS, which is around about 90% of pancreatic patients will have a KRAS mutation. We see a fair number with P53, although that's not targetable. And then there are sort of other mutations, as you can see here, going down the list. We come down the first column and up the second column. There are mutations here which we can potentially target, but they're relatively rare. So things like ATM or the BRCA, and you will occasionally get a BRAF mutation as well, but that's pretty unusual. So the frustrating thing with KRAS is historically it's not been targetable. You can see here all the varying KRAS mutations. The only KRAS mutation at the moment for which there is a licensed targetable drug is the G12C mutation, which you can see from the pie chart there is about 1.5 or 2% of patients. So the vast majority of pancreatic patients with the KRAS mutations are not targetable at the moment, but things are changing. So if we look at the G12C mutation, sotorasib is well known to those who treat lung cancer, which is a small molecule inhibitor that targets the G12C mutation. The CodeBreak 100 study evaluated this in patients with solid tumors. There were 9 patients with pancreatic cancer and a G12C KRAS mutation in this study. And of those 9 patients, there were 2 partial responses and 5 patients had stable disease, with a median PFS in the pancreatic group of 6 months, which is actually really not bad at all. And it was a very well tolerated drug, main toxicities being diarrhea, nausea, and fatigue. So what about beyond G12C? Well, there are drugs in the pipeline, and the one I'm most interested in, the G12D inhibitor, because that is probably the most common of the KRAS mutations that we see. But there's also a pan-RAS inhibitor currently in early phase studies. And as you can see, some of these others as well, which may also come through in the coming months and years. And that really will be a game changer for pancreatic cancer when you have a disease where 90% express a KRAS mutation. So what about targeting BRCA? Well, we have the PARP inhibitors to do that. Patients with a germline BRCA mutation is fairly unusual in pancreatic cancer. It's less than 5% of patients. But for those that do, there is this option for them. And theoretically, those with an ATM mutation as well. So we have olaparib and veliparib, and there are other PARP inhibitors in the class as well, like rucaparib and talazoparib as well. So looking at rucaparib, this is a study, it was a phase 2 study in BRCA or PALB2 mutated pancreatic cancer. Patients could have a somatic or a germline mutation, and you can see here that the median overall survival was almost 2 years. So the results were really quite astounding for this very small group of patients with this agent. What about in the adjuvant setting? Well, there's good data in breast cancer for adjuvant olaparib based on this study, the Olympia study. And a similar study is now going on in pancreatic cancer in patients with resected disease who've completed adjuvant chemotherapy treatment, are randomized to maintenance olaparib or placebo. And we await the results of this. This small subgroup with a BRCA mutation are also potentially more immunogenic as well, because you can see from this slide, patients here in the left-hand column with the BRCA mutation have a higher incidence of microsatellite instability, and they have greater PD-L1 expression as well, and a higher tumor mutational burden. It's still below 10, but it's statistically higher than those who are BRCA wild type. So there are studies now in place looking at the combination of PARP inhibitors with immunotherapy. The POLAR study is one of these. It's a phase 2 maintenance trial looking at olaparib and pembro following a response to first or second line platinum-based chemotherapy. So that would be FOLFIRINOX for most. Again, very excited to see the results of this, to see whether we can make a difference in a devastating disease to what is a small group of patients, but it will then hopefully open out to a much higher patient population. So coming on to immunotherapy for mismatch repair deficient pancreatic cancer, it's again a small group, but as you can see, there are lots of these little small groups. So hopefully we can make a difference as the number of these targeted therapies increases. So patients with MMR deficiency have a high tumor mutational burden, and there's neoantigen production, which makes these tumors potentially more susceptible to checkpoint inhibitors. There's limited data in pancreatic cancer because it's a rare subtype, but there is the Keynote 158 study, which evaluated pembrolizumab, and it's included 22 patients in the trial with MMR deficient pancreatic cancer, with a response rate disappointing 18% and a PFS of just 4 months. So you can see there's a way to go. And part of the reason is that many pancreatic tumors are not particularly immunogenic. There's another phase 2 clinical trial currently ongoing, looking at nivolumab and IPI, so IPI-NIVO essentially in patients with advanced solid tumors, and that includes MMR deficient pancreatic cancer. The POLO trial evaluated olaparib, the PARP inhibitor, as maintenance treatment in patients with metastatic disease after first-line chemotherapy. It was a reasonably big trial for pancreatic cancer, 150 patients, 92 in the olaparib group, with a median PFS of 7.4 months versus 3.8 months, highly statistically significant. So there was a trend towards improved overall survival as well, but it wasn't statistically significant. So we've got PFS without OS, and this is now standard of care in this patient group. Abacus looked at the addition of a PARP inhibitor in combination with first-line chemotherapy. So this was gemcitabine cisplatin in patients with a BRCA mutation, plus or minus veliparib. Patients were, it was a 1-to-1 randomization with an endpoint of PFS, 25 patients in each group. And again, very promising median PFS was double, actually, 16 months in the veliparib group compared to 8.4 in the chemo alone group, with a higher objective response rate as well of 85% compared to 65%. And these are very impressive results for pancreatic cancer. Other drugs in development, well, we have this pegylated hyaluronidase enzyme. I have to say the results that I've seen of this have been fairly disappointing. There's, as I've already shown you, a lot of ongoing work in immunotherapy, combinations of checkpoint inhibitors and novel immunotherapy agents as well. There's this agent SM88, which is a sort of metabolic inhibitor. You have radio-labeled lutetium PSMA, which is used for prostate cancer, but it's also expressed on many pancreatic cancer cells as well. So it's a potential radio-labeled therapy. And then for a very small subgroup who have an NTRK mutation, we have the TRK inhibitors as well. Many pancreatic cancer studies have been negative. Here's one example of a negative study. There's a randomized phase 2 of gemabraxane with or without combination immunotherapy, and you can see the survival curves are pretty much laying on top of each other there. It was a disappointing outcome with no significant difference in PFS or OS in this patient group. So I think it just shows we have to pick the subpopulations that are going to benefit most from these novel therapies. PRINCE is a first-line study in pancreatic cancer. It's a randomized phase 2. Again, looking at some novel drugs. You have gemabraxane with the checkpoint inhibitor nivo. There's an anti-CD40 antibody, sotigalimab, and then the combination of all three: the chemotherapy, the nivo, and the sotigalimab. And interestingly, it was the gemabraxane nivo where the results seem most impressive. So adding more targeted agents doesn't necessarily improve survival. And we saw that in colorectal cancer as well. When they combined cetuximab and bevacizumab together, the results were very disappointing. There are just really showing some other immunotherapy styles that are currently running. These are other immunotherapy trials. And some of the results you can see. There is one in particular, which is the O'Hara study from Lancet Oncology a couple of years ago, which did show some impressive results. That was gemabraxane with a CD40 antibody and with a checkpoint inhibitor as well, but very, very small patient numbers. So we're still awaiting more data on these patient groups. And then here are the major areas of therapy development at the moment. So the standard of care chemotherapy is FOLFIRINOX, and there's a study at the moment looking to replace the irinotecan with the liposomal version, which is Onivyde, and that's this study here, 750 patients. And then there are lots of phase 2s and phase 3s ongoing at the moment, looking at metabolic inhibitors or therapies targeting the stroma. We have, for example, the LAPIS study, which is a connective tissue growth factor antagonist in combination with chemo. Some unusual studies like PANOVA-3, which uses the tumor treating fields, sort of electromagnetic fields, which the patient has to place a box. It was the place a box over the pancreas. It has been used for some years for glioma, the tumor treating fields, but now being used in pancreatic cancer in the trial setting as well. So lots going on. You have the Claudin 18.2 inhibitors, olbituximab as well, which is showing a lot of promise in gastric cancer. Whether we'll see the same in pancreatic cancer, we'll have to see. And some immune therapy results pending as well. So lots going on. So essentially for all these patients, the minimum you want to really be doing is BRCA1 and 2, ATM and the Lynch genes, and somatic testing, obviously the KRAS genotypes. We need to know the microsatellite status. And this will really give you the minimum amount of information you need to know to be able to prescribe current licensed targeted therapies. If the patient's KRAS wild type, again, it's worth looking for rare fusions like NTRK as well, because you do see the odd one, and there are targeted therapies available. I'm just going to speak for a couple of minutes. I've done a lot about genomics, but just to say that radiotherapy is improving very rapidly in the 21st century. We can target pancreatic tumors far more accurately, and the side effects of radiation are determined by the dose going into normal tissue. So we can keep the dose well off the duodenum and the stomach here and deliver much higher doses to the pancreas using novel techniques such as MR-guided radiotherapy, stereotactic radiotherapy. And we can even track the tumors as they're breathing. You can see in this middle picture here, there's a pancreatic tumor, and the beam will only come on when it's within the region of interest. And it's making a difference in combination with improvements with systemic therapy. Here's some data from locally advanced pancreatic cancer showing that median survival now with SABR treatment is around 26 months, 1 year survival of 82%. So a massive step forward. And here you can see stereotactic radiotherapy treatment compared to conventional external beam radiotherapy gives you that improvement in median overall survival because you can get the higher dose in, and with one year PFS of 75%. And then if you look at this graph here, the patients that are tolerating neoadjuvant chemotherapy in addition to stereotactic radiotherapy, median OS for this group of 21 months. So that's almost double what it used to be 10 years ago. And we can target, for example, patients with oligometastatic disease. This is a bit of an exceptional case. This was a patient with pancreatic cancer that wasn't tolerating chemotherapy. It was absolutely wrecking his quality of life. He had 7 or 8 small liver metastases, which we irradiated using MRI-guided therapy. And he managed, had a 6-month progression-free survival, 6 months off chemotherapy with good quality of life and time with his family before he relapsed. That's my presentation. Thank you.
Thank you very much, Dr. Andrew, for that very fascinating talk. I think it's still a way to go with pancreatic cancer until we reach really survival. There's one promising clinical trial where, again, a combination, I guess it's a more toxic combination of chemotherapy and targeted therapy looks to be so promising, at least in one subgroup. The question is, when we have such small groups, is the common way how we create evidence for this particular type of cancer the proper way, or do we need to change our thinking about how we create evidence? What's your go for that?
Yeah, I think that's a really, really interesting question when you've got these very, very small subgroups and rare mutations in rare cancers, for example. I think we need to look at internationally the way that drugs are licensed. and move away from site-specific licensing to licensing on the basis of what the drug targets. So sotorasib, the KRAS G12C inhibitor, there's got a license in lung cancer, but it doesn't have a license for pancreatic cancer. So when we use it, it's off-label. The insurers often won't cover it, and we run into problems. So I think that is one way things need to change. And I think there are innovations as well in the way clinical trials are performed. I think basket studies now, we have this sort of very small basket studies, and I think we're much better now with international collaboration. So again, I mean, anal cancer is a good example of that. Metastatic anal cancer chemotherapy, that study could only be run globally because the vast majority of patients with anal cancer are cured, and it's the only way to recruit within a reasonable time frame. So there's a few things I think we can do better.
Maybe one. Oh, Dr. Baal, you have a question? Yes, please.
Yeah. Thank you, Andy. That was 30% of my talk, which you made easy. So, Andy, straight question to you: the 10 to 15% of my pancreatic clinic are unresectable and they are non-metastatic. They are unresectable upfront because of the vasculature locally advanced, and there are no liver metastasis. And we know pancreas is a retroperitoneal organ with lots of desmoplastic stroma. And because of that, nab-paclitaxel or Abraxane, because of that spark protein, was famous a decade ago. And you mentioned about radiation. So many of those patients in which biopsy is not possible, we rely on EUS-guided FNAC for that malignant cell, and we label it to start our chemotherapy protocols, and we give FOLFIRINOX, and then we give a bit of SBRT that has given some survival. So my question is, can we make this cold tumor where tissue is an issue by a liquid biopsy, giving them chemotherapy upfront, then giving them some radiation? Can we produce some neoantigen where this IO can work with nab-paclitaxel? Can you modify the stroma, and can you modify the immunogenic potential of this tumor?
Yeah, I mean, there are, it's the holy grail in radiation oncology is this combination with immunotherapy, and it did show a lot of promise in melanoma, and there've been some early studies in locally advanced pancreatic cancer looking at the combination of stereotactic radiotherapy, especially with immunotherapy, and so far at least the results are disappointing. And in metastatic disease as well, there's the other holy grail is the abscopal effect, isn't it? But and there's a lot of debate now whether it actually exists or not, but it's certainly in some tumor sites, melanoma, I've certainly seen that. But it's a huge challenge for a tumor that classically is not particularly immunogenic. And I think there's a lot of work to do. But I agree with you. We have to do better. And I think the SABR is very exciting because we're downstaging more and more to resectability. But also, I think what's very exciting, we've seen the advances in systemic therapy, advances in radiation. We're now seeing a lot of advances in surgical oncology as well, in terms of what surgeons deem to be resectable or not. And ours are regularly doing now, major vascular graft. So what 10 years ago was an unresectable pancreatic cancer is now resectable with grafting.
Thank you very much, Dr. Gaia. Really fascinating. We start now with the next presenter, Dr. Ankur Baal. He has more than 15 years of experience in the field of cancer. He is an alumni of Maulana Azad Medical College, Delhi, where he did his MBBS, followed by MD Medicine. He's the lead author of largest real-world Indian data on targeted therapy, head and neck cancer, acute myeloid leukemia treatment, human papilloma virus trends in Indian population. Dr. Baal has joined FMRI Gurugram from Max Hospital, Saket, where he was director, medical oncology and hematology. Previously, he was associated with prestigious organizations like Rajiv Gandhi Center Institute and Research Center and Maulana Azad Medical College. I hope my pronunciation was not that bad, to be honest. He will update us on genomics and their role in GI cancers. Thank you very much. The stage is yours.
Thank you, Stefan. Thank you for this kind announcement. So thank you, Datha Cancer Genetics, and I hope Bangladesh oncologists are also on board, and we are able to discuss genomics of gastrointestinal cancer. So genomics till now, as Nitesh said and Andy said, it was the poster boy of genomics in cancer is in solid cancer is lung. So however we see, and it's been a decade or a 1.5 decade practice of determining biomarkers in various colonic, various gastric, various pancreatic, and now biliary tract cancer. So our part of the world, North India, going towards the Eastern India and Bangladesh, gallbladder cancer gallstone is an endemic state. And majority of our gallbladder cancers have gallstones. 80% of our gallbladder cancers have gallstone, and we see a drastic change when we go to South India, the southern part of the country. We rarely see gallbladder cancer. So there is a variation. There's a genotypic and phenotypic variation in our biliary tract cancer, and we need to know as an oncologist, and we have presented our paper in ESMO this year on genomic profiling of BTC cancers from India. So biomarkers in GI cancer is well-known phenomena. It's nothing new. So GI cancer basically divided into colorectal, hepatobiliary. BTC is now 4 types of cancer, and now we have gastric and esophageal cancer, and particularly at G-junction tumors. So biomarkers in GI cancer, the basic biomarkers we all have been practicing. So how we can move to precision oncology in GI cancer is the key question. And next 10 minutes, I'd like to just highlight how from bench to bedside, these biomarkers are helping us getting that increased overall survival, that local control, and the quality of life as well. So various biomarkers across all GI cancers. We start from BRAF status in colorectal, HER2 new targeting in colorectal, the new MSI high guidelines where we can use this IO-IO combination in upfront colorectal cancer. The gastric G-junction and the esophageal cancer is a new thing. So upfront we are testing PD-L1, upfront we are testing HER2 new positivity, so that we can use this chemotherapy and targeted therapy, or chemotherapy plus IO, or IO plus IO in this gastric cancer. As Andy said, pancreatic cancer, we have targets, we have those driver mutations, but since they are so rare, so getting a positive result, a cumulative positive result across the nation, across the world is difficult. So we need to collaborate in pancreatic cancer, where we can accumulate all these patients and give the world that what is best for pancreatic cancer. Nitesh rightly said that cholangiocarcinoma is a new lung cancer, diverse mutations, diverse actionable and driver mutation from IDH to FGFR, from KRAS 1 to C. So, and the tumor agnostic criteria where we can use as a basket these IO or IO plus targeted therapies across various indications. So let's start with the colorectal cancer. So I've said last 15 years, we're using KRAS, NRAS, or a BRAF status. Then we move on to HER2 mutation. And beyond KRAS, NRAS, when we had BRAF mutated agents, then we had got MSI status, TMB. So colorectal cancer, initially we started with wild type or a mutated RAS. Now in wild type as well as in mutated, we have various subsets where we can introduce these targeted agents, where we can introduce this BRAF inhibitor and combine this BRAF inhibitor with anti-EGFR, and combining this doublet with a MEK inhibitor, the BECON study, we can get some survival, some PFS and OS advantage, even in second and third line agents. So preferred therapy in GI oncology, whether it is esophagus or colon or rectal or BTC or a pancreatic, sequence is always in our mind. So whenever we start a practice of operation in a medical oncology OPD, we have to think about what next and what next. So sequencing of these agents is of utmost importance to give that survival advantage to our patients. And we start with pan-RAS testing, BRAF testing, whether it is a wild type or a mutant type. And then if it's a mutant type, then we choose bevacizumab or angiogenetic agent. Or if it is a wild type, then we decide it is left side or a right side. And we use this combination, the cytotoxic agents, along with either an anti-EGFR or an anti-VEGF molecule upfront. And there's always a tendency in GI cancer from oncology perspective to find a driver mutation or to find an MSI high status where we can use these agents, where we can use this agents like pembrolizumab in a MSI high status in the second line, pembrolizumab in a high TMB status, more than 10 mutes per megabase, or we can use that anti-RK gene fusion inhibitors, or we can use BRAF. So all these agents we have to keep in mind, either through a liquid biopsy or a solid biopsy or a combination of this liquid and solid, so that we can use these agents in a second line patient. So as I said earlier, sequencing matters. And now in second line or third line in colorectal cancer, we have plenty of option from our armamentarium, from the drugs which have been used previously, the drugs which are left behind, and the correct sequencing on the basis of liquid biopsy, on the basis of retaining that RAS wildness, we can re-challenge this cetuximab or panitumumab as Kronos trial or a cricket trial. So in second line, we heavily rely, if we get a driver mutation, either a BRAF1 or we get an MSI high status or a deficient MMR status, we get rare mutation NTRK or an HER2 mutated or an amplification. So this is a Keynote 177 trial, which says that in an upfront MSI high status, pembrolizumab compared with chemotherapy is certainly better in OS and PFS. This is Checkmate 142, which says that IO plus IO combination, nivolumab plus ipilimumab in an MSI high setting in a metastatic colorectal has given advantage with the overall response rate of as high as 69 to 70%. This is a Bacon CRC trial, which says that encorafenib, cetuximab, and binimetinib for BRAF, specific BRAF V600E mutant colorectal cancer in a second line as compared to the control is better. And there are various attempts of targeting HER2 targeted regime for advanced colorectal. It could be trastuzumab, trastuzumab, tucatinib, trastuzumab, and the Destiny trial, which says that Enhertu with the overall response rate of around 45 to 60% can be given in a second line patient which is HER2 mutate amplified. So these are various biomarkers apart from KRAS G12C, where AMG510 or sotorasib HER2 amplified. We have many combination of dual HER2 targeting, RSP02, ARIDI1, NRG, and MSI status. So there are plenty of agents which can be used to increase the survival of this colorectal cancer. So coming on to the gastric and gastroesophageal junction cancer, again, the algorithm has changed. The algorithm has changed. Upfront, if I get a G junction or an esophageal or a gastric cancer, I straight away test HER2 through IHC and straight away simultaneously send a PDL1 sample for a CPS scoring in a gastric or a G junction tumor. For what? For an overall survival benefit, how I can judiciously use my cytotoxic agents with anti-HER2 molecule or my cytotoxic agents with a immunotherapy combination. So biomarkers are emerging in gastric and G junction. And I would say that the GI cancers are third or fourth most common practice in a medical oncology, especially in Northern India. So in a newly diagnosed gastric cancer, 5A few platinums with nivolumab if CPS score is more than 5. And if you get a HER2 positive gastric cancer, there's a guideline according to the Keynote 811, straight away addition of pembro with trastuzumab with FOLFOX, or same is in G junction where in CPS 10, we can add Keytruda or Keytruda plus platinum 5FU as per Keynote 811. So this is a TOGA trial, very famous Kaplan-Meier, which says that chemotherapy with trastuzumab versus chemotherapy alone gives a OS benefit, and this has been published in TOGA trial. This is Keynote 811, which says that in HER2 amplified gastric cancer, we can straight away add IO plus trastuzumab with chemotherapy, and you can see the waterfall plot. It's a huge response rate of 75% in a metastatic gastric cancer when we compare with chemotherapy and trastuzumab and a placebo, which was just 60%. By adding pembro, the overall response rate goes 25% up in the favor of Keytruda and trastuzumab. This is Checkmate 649, which says that IO plus IO combination in a gastroesophageal cancer could be better when compared to chemotherapy, and it is across all PD-L1 subgroup less than 5 or all randomized trial. This is Keynote 590, which says that pembro plus chemotherapy is better than chemotherapy across all randomized whether CPS is more than 10 or CPS less than 10. Obviously, we can see that in CPS more than 10, the hazard ratio was 0.62, and in all randomized population, the hazard ratio was 0.73. So PD-L1 is a biomarker. HER2 amplification is a biomarker which should be tested upfront in all upper GI cancers, gastric, gastroesophageal. And so this is Destiny trial, and HER2 in previously treated HER2 positive gastric G-junction adenocarcinoma. So those patients who have progressed on more than 2 lines of anti-HER2 or a cytotoxic agent giving Enhertu, comparing with the standard chemotherapy by a physician choice, is giving a survival, both PFS and OS, in favor of Enhertu. So Destiny trials said that the overall response rate beyond second line when we treat with trastuzumab deruxtecan can be as high as 35 to 40% in such settings. Coming on to the biliary tract cancer, it is one of the commonest cancer we see in northern India and Bangladesh area. The gallbladder stone, the inflammation, the cholecystitis, the chronic cholecystitis is one of the most common reason of giving gallbladder cancer in our area. But it is coming with huge genomic alteration. So biliary tract cancer, I would say it's being divided into 4 parts: intrahepatic, extrahepatic cholangiocarcinoma, the gallbladder cancer, and I say the periampullary cancers are also the inflamed one because of the chronic cholecystitis, the chronic cystitis in our patients who have gallbladder stone. And these genomic alterations are well seen in our country with high ERBB2 or HER2 amplification, with a lot of IDH mutation we see in intrahepatic cholangiocarcinoma and even in gallbladder cancer. And very interesting, the FGFR fusion and amplification where we can target. So this is a target-rich disease. I would say that if lung cancer is a poster boy, then this could be a next poster boy, particularly from our region, our country, where we see lots of cholangios and gallbladder cancer, and we see many of them can be targeted with either IO or NTRK inhibitors or FGFR inhibitors and or ivosidenib. I have 4 or 5 patients of ivosidenib of cholangio and gallbladder cancer, showing a good 11 months or 12 months overall survival post first line or second line of standard chemotherapeutic agents. So the world in BTC have changed after NEGM Topaz 1 trial, where durvalumab was given to standard gemcitabine and cisplatin, and we can see that at 2 years, there was a 2-year OS, estimated OS benefit of around 13 to 14 months. However, the median OS was not that impressive when the trial was started with, but once the patient responds to durva and cisplatin and gemcitabine, and then we continue this patient on durvalumab, particularly we have seen in our patients that few of my patients are going beyond 1 year on durvalumab, and it is pretty impressive in first line maintenance. So 2 FGFR inhibitors for cholangiocarcinoma, pebigatinib and futibatinib. So they have both shown an overall response rate of 35 to 40%, and particularly in second line when the patient have failed the standard first line of gemcitabine and 5-FU, these agents can give you another 1.5 years if given and if they respond. This is this 5202 FGFR inhibitors in cholangiocarcinoma. Beyond 2 lines or 1 line, the patient the median PFS of 6.9 months and median OS of 21.1 month is pretty impressive with this FGFR inhibitor. So we are especially looking forward for these drugs when they will be available in our country. So so much burden of these cancers, cholangios and GBs in our country. So these drugs will be of great benefit to us. So the combination of dabrafenib, trametinib, which are using in various BRAF inhibitor, BRAF mutated solid cancers. So these cholangio and gallbladder cancer can be benefited from this combination. So these are various attempts of randomized trials of biliary tract cancer, various phase 3 and phase 2 trial, which seems promising. So the first line of Topaz-1 trial was over a decade. There was nothing nothing beyond gemcitabine and platinums in BTC. So this durvalumab or IO attempts with chemotherapy will give overall survival, and that will help our patients. Andy has touched pancreatic cancer in detail, so I will skip for it. And I'll just take 30 seconds more. So there are emerging strategies in GI cancer treatment. So special investigative targeted therapeutic, especially in Claudin 18.2 positive cancer, FGFR amplified cancer, NRG fusion cancer, and as Andy said, KRAS G1TC, where we have a drug which can be benefited in these patients. So toward summarizing these GI cancers, if we combine this cytotoxic with a perfect IO combination, or in second line, if we give a targeted therapy against this driver mutation, which could be either a FGFR or an IDH mutation, we can get a good survival, OS survival, even in this patient who have failed standard first or second line. With this information, I'll rest and open for criticism or comments. Thank you.
Thank you very much, Dr. Ankur. This was fascinating. As said, I think you have the next poster boy already in your portfolio. Are there questions from the audience at the moment? If not, I have a question. What becomes apparent, it's not just now with lung cancer, but the use or the need for more complex diagnostics tool. Where do you see, because when I look again over here in Europe, it's maybe not the matter that somebody can afford an NGS machine, but the people behind the NGS machine are sometimes the operator, I would say. And how do you see this in your area? What's your feeling about this?
So my feeling, if I divide GI cancers into 4 parts, certainly yes, in BTC. In biliary tract cancer, I want to ensure that I get a driver mutation upfront so that I can combine various drugs or cytotoxic or IO together so that I get a response. I'm not very much convinced in our country regarding pancreatic cancer because tissue is an issue. So if later on I can get an FGR amplification or an IDH mutation somewhere around the line, I'll be happy. But the most important is testing that biomarker, and BTC is an organ. BTC is an area where these liquid biopsy or a combination of liquid and solid biopsy can help our patients, particularly with FGFR and IDH coming up.
Yeah, because this would have been my next question. What do you think about liquid biopsy in this area, and what are your experiences there?
So if we see the genomic alteration in biliary tract cancer and pancreatic cancer, Andy has said, I have said in my slide that 25% of pancreatic cancer have some genomic alteration. They could not be targeted. Yes, we do not have the agents right now. But in biliary tract cancer, we have agents, we have approved agents in second line or beyond. So, and these cancers give us very less time. The overall survival of these advanced pancreatobiliary, pancreas, GB, or cholangio is not beyond 1 year, 1.5 years. If we get a specific target upfront, if we get a specific pathway upfront, we can utilize this genomic alteration for an overall survival benefit. And our land is full of gallbladder cancer. We have genomic alteration probably more than rest of the world. So we can tell the rest of the world, what are our specific genomic alteration and which drug may act in our area as compared to the Western population or a UK population. So I'm thrilled if we can get a data in next 5 to 10 years on BTC, where there's so many patients, and we can get so much database of these patients.
Thank you very much. I introduce now the next speaker, Dr. Svante Limaye. We have met, I guess, 4 years ago in Mumbai, if I'm not mistaken. Dr. Limaye received her medical degree with honors from Jawaharlal Nehru Medical College, Bhagalpur, India, and did her residency in internal medicine from New York University, a fellowship in hematology and medical oncology at Albert Einstein University, New York. She's director of medical and precision oncology at Sir H.N. Reliance Foundation Hospital. She has been involved in research leaders at Memorial Sloan Kettering, Dana-Farber, Columbia University, and National Cancer Institute, USA. She has been awarded with the John Flynn Young Investigator Award for Excellence in Clinical Research, the Rose and Jack Horowitz Award for Excellence in Patient Care, and the Medical Oncology Research Excellent Award, ESCO 2008. She will talk about comprehensive cancer diagnostics. Thank you very much. The stage is yours.
Thank you, Stefan. We met at the MAP meeting in London.
There it was.
Yes. So pleasure to be participating in this great event. I will try to bring my perspective forward. I believe in an N of 1 approach, and we heard different malignancies. Now we're going to put it all together for all malignancies. And here's my disclosure. I'm a precision oncologist, self-proclaimed. Of course, medical oncologist by profession, and I also direct the clinical and translational oncology research division at my center. So these are my disclosures. It's a huge honor today to be sharing the stage with all the esteemed colleagues that we just heard, and also a disclaimer that I've been working with Datar Genomics for the last 7 years. That I have been here in India, and it's an honor and a pleasure. The journey has been very interesting. So my precision journey starts with HER2 story when I was, and this slides actually dates me. When I was an intern, I was given one of my first projects, which was a data collection on HER2 positive metastatic breast cancer. And then when I went to Dana-Farber as a faculty, my first project again was a HER2 positive salivary duct cancer project, which we published in the Oncologist at that time. And one of my biggest influences was this patient, where we found in a 40 gene panel, we found the patient to be HER2 mutated, HER2 amplified. And this was a head and neck patient. We ended up utilizing trastuzumab in a head and neck patient who went into complete remission. And then again, I was assigned the HER2 arm in the NCI match, the arm B, which I was in a national chair, and I co-chaired that with 2 other colleagues and wrote the arm B, which was the HER2 arm. Now, the HER2 pathway itself, and we heard Dr. Nitesh Rohatgi and also Dr. Ankur Bahel outline how the pathways affect the disease systems. But we also know that that's not where it ends. So 10 years down from where I started, or 15 years from where I started, why haven't we been able to use genomics ubiquitously in everything that we do, even though what I told you about the HER2 story was a single pathway, single gene, single pathway directed approach in those times. And here are we today. We are still looking at 20%, 40% capture rates of any pathway directed therapy. 60% of our applications are still untouched, and still we are unable to figure out strategies for our patients who we sequence. So why do we feel that? Because are we not able to interpret? Are we not able to apply what we see in the comprehensive genomic profiles, or is it not enough? One of the answers that I have found is because organ-based guidelines, we just heard about organ-based approach. So organ-based guidelines are just about happening. So organ-based guidelines are just getting organized. And then we are talking about disorganizing, which means we are talking about picking up messages from one organ, taking it to the other organ. And if I look at it, it's looking for a sock in a clothes pile. You know, you have a huge pile of expressions and pathway declarations, and you're trying to figure out where to apply and how to apply. And sometimes you end up wrongly applying it on your head, as this cat has done. And then again, there is this tumor agnostic application, and we have so many FDA approvals that have already happened, and so many that we are aware of and pressing and waiting to be discovered. Then there's this tumor presence of the tumor and expression, and then the host immune expressions and the entire immune biomarker lack of discovery, which is a huge challenge and criticism to this entire approach. We don't have adequate data. Where we have data, we don't have data talking to data. We have different barriers. And of course, then there is what we think genomics as the tip of the iceberg. And when I took this slide from Dr. Ray Kurzrock's slide and put it in and was in a presentation, one of the audience members pointed out that I'd not included metabolomics in that. And so in this slide, I have added to Dr. Kurzrock's slide as metabolomics. So you can see that genomics is just a tip of the iceberg. There's intratumoral and intertumoral heterogeneity, there's drug sensitivity, and there is this entire organoid world where we are trying to interpret from what we see in the tumors and study it in mice, in other organoids, and trying to really assess what we see from one sample to the other sample, and join all of that into trying to understand what cancer is. And this is an illustrative slide. I don't need to speak anything. This is borrowed from a good friend, Dr. Nirmal Raut, where we say nine-headed hydra. This paper by Vivek Subbiah and Ray Kurzrock is self-explanatory. And then you have the 6 blind men and the elephant interpreting the different genomic data. And of course, what Vivek Subbiah said in one of the meetings, cancer is like 10 heads of Ravana. And you shoot down one, the other head will emerge. This is the Indian mythology where Ravana is a demon. He has 10 heads, and you shoot down one head and the other head emerges. And how do you catch up with all of that? I present this case to build a context to a few cases that I'm going to present as illustration for comprehensive tumor exacta analysis, which is a multi-analyte testing I'm a huge fan of. And I moved over to comprehensive tumor exacta way back almost 5 years ago, and was heavily criticized for that because it was ahead of its time. Today, I feel the time has arrived. So this is case 1, where we talk about a 36-year-old male who presented with a right tongue cancer and underwent surgery followed by radiation for that. A year later, he develops a lung lesion with ribble involvement, which was thought to be a lung primary. So that gets resected, and the patient gets treatment for limited lung cancer, early stage lung cancer with cisplatin etoposide, radiotherapy, which had followed surgery. Next thing is that the patient needs now treatment, and a PET scan gets done, and this shows progressive disease. Whether this was lung, whether this was head and neck metastasizing to lung, we don't know. But the problem still stays. So the patient, now considered platinum resistant, was treated with gemcitabine, paclitaxel, and pembrolizumab because there is PD-L1 positive disease. The next scan shows that the patient has progression of disease in the brain, and there is further progression after radiation to the brain. And here's the liquid biopsy. Here's the comprehensive genomic profiling from the tongue. This is a PD-L1, 30%. comprehensive genomic profile from the tongue shows P53 mutation, and also a germline, because this was a 36-year-old patient. I do germline in any young patient. This patient, again, shows nothing. So where are we? Does this help me? And I'm left limited to therapy application and actionability. As we discuss actionability, how do we define precision? Is precision only a single gene finding? Is it an IHC-based finding? Is it a hotspot finding? Is it a CGP finding, chemosensitivity, tissue, liquid, or all of the above? And really, what entails actionability? What is actionability at your center? Do you have access to CGP? Do you have access to beyond CGP? Do you have access to interpreting teams? As we just heard, you cannot just alone be able to interpret all of this host of information, explosion of data. We've seen this in multiple trials, precision-directed trials that have happened in the past, and some of them are listed here, where you have the Winther trial, the My Pathway, the MD Anderson Cancer Center phase 1 data presentation, the Von Hoff study, and many, many more. Of course, the Shiva trial, I actually didn't even mention. So many of these trials looking at different kinds of precision-directed treatment approaches, showing how, as we evolve, it is actually multi-analyte, multi-pathway. And here's a table that entails some of the precision-directed studies that have been published, which and their therapy selections based on single agent. Some of them were multiple pathway-driven. Some of them were microarrays. Some of them were hotspots. Some of them included RNA-seq, whole exome sequencing, and NGS. And it's totally a variation of all kinds of strategies to approach precision. And then a couple of examples where this Biocon study, if you have a single gene in a context of a different disease, will behave differently. You have iPredict study, where you have molecular profiling, where matching score is developed in an N of 1 approach. And in that matching score, it was shown that patients who had a matching score above a certain percentage had a higher survival with dual targeting. And actually, if you see a particular section, dual targeting and chemotherapy. And that brings me to an N of 1 discussion, where I think it is iPredict and it's Resilient. Resilient is a homegrown trial with comprehensive tumor exacta analysis. It was a phase 2, phase 3 study. I wasn't a part of the study, but I'm a huge fan of the test, and that's how I'm presenting this. It includes 453 gene analysis, tumor-based, a ctDNA 52 gene analysis. It also has gene expression analysis, exosomal microRNA with 756 transcripts. You have the IHC marker. It has pharmacogenetics, in vitro chemosensitivity, which I find very relevant. And of course, the bioinformatic, collaborative bioinformatic interpretation. And if you look at the overall response rate from the study that was published in OncoTarget, you have significant overall response advantage in comparison to all the precision trials that I just showed, 42.9% versus all the others that you can see on this slide. And the PFS2 versus PFS1 significantly higher than what was proposed to be the cutoff. And that is something that one should take note of, because it's a conglomerate of all multi-analyte tests as well as the chemosensitivity analysis. And this is a case that is illustrative, a head and neck case that is illustrative and treated with a chemotherapy drug that is not head and neck specific, with two targeted therapy drugs that are also not head and neck specific. And a picture is worth 1,000 words, and you see that here right away. With that, I come to a case number 2, where there's a 48-year-old male who has no history of tobacco chewing, develops left tongue ulcer. And I contrast this with the last case where I didn't have an option to treat. But this is a patient who has no history of tobacco chewing, presents with tongue cancer, undergoes surgery, reconstruction, and while getting prepared for radiation, develops progressive disease. During preparation for radiation, develops progressive disease. He's found to be PD-L1 positive, is started on carbo-nampacli, and pembrolizumab is added. Patient responds. While the response is happening, the patient is tired of the chemotherapy, and so the chemo dose is delayed 2 weeks. And during that treatment, during that gap, the patient shows progressive disease in the left neck. And that progression then gets, you already have done tumor exacta analysis, and this is the tumor exacta analysis. So we were already prepared at the time the patient has progression. So this tumor exacta was not implemented at the time of the treatment with the Keynote 048 regimen. Chemotherapy plus immunotherapy was given as per standard of care, but tumor exacta was done in the vicinity. And here it is, we find that the patient is PD-L1 70%. The patient is also PIK3CA mutated. The patient has an HRAS mutation. The patient has chemosensitivity to carboplatin and 5-FU amongst the other test results. And there is overexpression, gene expression profiling shows overexpression of PDGFR-A, PDGFR-B, VEGFR positive disease. And so this patient was then, sorry, I'm not able to move the slide. Yes. Okay. So this patient was then treated with chemotherapy as per the chemosensitivity analysis. This patient was also given lenvatinib for the gene expression profiles that were shown, and trametinib for HRAS, although the right drug would have been tipifarnib, but we didn't have access to that. So trametinib was given, a downstream signaling inhibitor. Patient has had a near complete response and was able to undergo a resection of this lesion. So that's an exacta directed treatment where chemotherapy was changed to the chemosensitivity that was shown, and gene expression profile was used to treat in a comprehensive way. The next case is an advanced colorectal cancer. It's a 70-year-old male with advanced colorectal cancer, which was all RAS negative, all other targets negative. Patient started on FOLFOX cetuximab, has a durable run on that, progresses, FOLFIRI-Bev progresses right away, capecitabine panitumumab progresses right away. Dilemma, what do? You do a biopsy and a liquid biopsy. In the liquid biopsy, now the patient manifests KRAS. So we know that there is a RAS evolution. For this patient, it was a RAS evolution that had happened. So the patient had a cetuximab sensitive tumor that lost the sensitivity, became insensitive, and then later on, again on a repeat biopsy, found the sensitivity to cetuximab because KRAS evolved. However, this patient was again treated with exacta-directed treatment, was given mitoxantrone, which is not utilized as a colorectal drug at all, but the patient had already progressed on multiple lines. I didn't mention many other chemotherapies that were given in the interim. Pembrolizumab, lenvatinib, and trametinib, and the results are right here. The liver was completely full of disease, and the patient almost had a near complete response. Then there's a patient with cholangiocarcinoma, 53-year-old gentleman who presents with advanced cholangiocarcinoma with a single brain metastasis, which undergoes gamma knife surgery, and the liver metastasis that now forms the systemic disease. And this patient was found to have PD-L1, PD-L2 amplification, ERBB2 amplification on a Foundation 1 report, was studied for HER2 by IHC, and IHC was 3+, PD-L1 was 65%. And this patient, of course, has, the poster boy, changing poster boy from lung to biliary tract, as we heard Dr. Ankur Behel speak. So this patient was very, very target rich. But even after giving HER2-directed therapy and pembrolizumab, this patient had progressive disease. And then tumor exacta analysis was done and a chemo scale was calculated where the chemosensitivity testing showed that the patient would be sensitive to these two chemotherapies. And finally, the patient was given exacta-driven chemotherapy, immunotherapy, and HER2-directed therapy. And you have the images on the right side with near complete response to treatment and durable response to treatment. Case 5, hormone-positive breast cancer, advanced after initial therapy with epirubicin, cyclophosphamide, docetaxel. This patient was ER/PR positive, HER2 0 by IHC, Ki67 was 60%. Initial surgery followed by adjuvant therapy, followed by tamoxifen. Develops metastatic disease, multiple liver lesion, heavy disease burden. Was started on palbociclib and letrozole because the liver enzymes were intact. Almost immediately had progressive disease with increased liver disease burden. Was put on nab-paclitaxel and denosumab for the bone involvement, and then switched to everolimus exemestane when started progressing, developed rising LFTs, impending visceral crisis. This time, exacta gets done, and on exacta, the patient is found to be sensitive to certain chemotherapies, also with ESR1 mutation, ESR1 increased expression, and so the patient is switched to exacta-driven treatment with gemcitabine, bevacizumab, capecitabine, and fulvestrant. And this patient has a run of 17 cycles, even with that much of disease burden in the liver. Progresses, repeat biopsy, repeat exacta, this time platinum sensitive, also with germline BRCA, because in exacta, you also have germline testing. Patient switched to carboplatin and olaparib, again has a run with 7 cycles, and this is the last PET scan. One of my last cases, 50-year-old female with advanced triple-negative breast cancer, heavily pretreated, immunotherapy, multiple lines of chemotherapy, all of that given, then exacta done, and EGFR amplification and EGFR expression on gene expression profile, treated with dual EGFR inhibition, cetuximab and gefitinib. This is a dated picture because now there is no ulcer. The entire ulcer is gone. I couldn't get that picture for the for our presentation here, but now there is no ulcer at all. There's just whitish discoloration of the skin where the ulcer used to be. So in the end, I would say, as it is said in the I Predict publication, we have to all try to gather it together in a multi-analyte understanding of that patient in an N-of-1 directed manner and deliberate in a molecular tumor board, which is most critical. We at Reliance Hospital run multiple molecular tumor boards, multiple initiatives. With the help of Datar Genomics, we run our molecular tumor board once a week, where we are deliberating on their cases. And we do that with other lab partners like Foundation, like other partners as well. We also run Impact India International, ILON Precision Oncology. It's all about people coming together to deliberate what the application of the precision data should be. We are enriched with so many drugs and the huge amount, the truckloads of drug development that is happening. We need to learn to utilize them. We need to understand our biomarkers and implement beyond CGP. The future is now, and time to slay the 9-headed Hydra. Thank you so much for this opportunity. Hope I've conveyed the central message, which is multi-analyte testing is the way to go. And chemosensitivity is something that we can't leave behind. Gene expression profiling is something that we can't leave behind. 60% of the lack of actionability of what we call precision medicine, 40% is all that we get out of CGPs. We need to look beyond that 40%, and the other 60% is where we really get defeated. That's what we need to concentrate on. And the data from comprehensive tumor exacta analysis is ever powerful. We need to implement that. Thank you so much. Thank you, and open for questions.
Thank you
much, Dr. Svanti. Are there any questions at the moment from the audience? If not, then I have a question. What we have observed in the past 4 years when we had Exacta patients in Germany, that when we are doing also, we are able to do derive data from ascites, data from blood, tissue-based data. What is your approach to use those methods in anything else but tissue and blood, where it's basically more common? And how do you deal with that, if I may ask?
So it's a great question. And Darshana is here. Dr. Darshana is here. And between her and me, we just did a CSF test. And we found out that the patient was EGFR mutated. And we gave osimertinib to a patient who was bedbound, leptomeningeal disease, and at least a month and a half had been on the bed. The patient is much better. The son just came to thank me, but the credit goes to Darshana. So I think we need to be innovative. We need to think out of the box. We really need to be chasing this in every sample that we can chase it in. I call it the silver lining. You know, these are cases that are advanced. If you've got to find the silver lining, you really need to run for it. And sometimes it's not just one. EGFR mutation is truly, it's lucky. But sometimes you have to piece all the information together. In the last case I showed, this is a patient who is a single mother. Her husband we lost out of advanced head and neck, where we couldn't do any genomics, explosive disease. We lost the husband. She is a single mother. The son funds her therapy, and it was only because of Exacta that we were able to finally hit. I think it was 8th line of treatment that we were able to piece it together to hit the EGFR receptor from both sides. And here is the result. So I think we really need to think out of the box. We need to be the Sherlock Holmes.
Indeed. Thank you very much. Are there any other questions so far? No? Then thank you very much, Dr. Svanti. I hope to see you soon again.
Yes. Sure.
I want to introduce now Dr. Darshana. Ever source of knowledge to me, to be honest. I think she gets from me per week at least 5 to 10 questions on more complex cases. Dr. Darshana, she received her medical degree from Rajiv Gandhi Medical College and Chhatrapati Shivaji, sorry for that, Maharaj Hospital, with masters in molecular oncology from Spanish National Center in Coimbatore Medical College. She's a medical director at Data Cancer Genetics with more than 10 years of experience and medical practice in healthcare industry and cancer research, genetic and molecular testing, leading with new test developments, pathology, biotechnology. She's thoroughly engaged in developing of clinical research designs and implementations, and she will talk about the future in genomics. Darshana.
Thank you, Stefan. It's very difficult to snap out from Dr. Limay's presentation. It was awesome, but still I will attempt, and I will be brief because we are already short of time. Thank you so much. So I'm really focusing on utility of multi-analyte genomics, going beyond the conventional NGS profiling. I think it has been enough has been discussed that no longer it is about the histopathological subtyping or the conventional microscopic examination. We have to look at the tumors with molecular microscope, which is NGS analysis. But what we do with NGS also makes a vast difference in what kind of information we can achieve for our patients. So along with like adenocarcinoma, now even squamous cell carcinoma of lung requires broad molecular profiling because there has been increase in so many targets, and we want to give the possible benefit to each and every patient of ours. And as has been already discussed, that the utility of liquid biopsies going beyond the conventional tissue analysis is also finding its foot in even routine guidelines. For example, in lung or melanoma or breast cancer, there has been recommendation of liquid if there is no availability of tissue. And but of course, we should know the limitations of each analyte or each methodology which we opt for, and I will focus briefly on those. So beyond the poster boy lung cancer, now we have multiple cancers in which the comprehensive genomic profiling is finding its way. Like cholangio, colorectal cancer, ovarian, endometrium, melanoma, GIST, the list is endless. And this is also, now we also know that the recommendation of comprehensive NGS profiling is finding expanding utility because of the increasing organ agnostic approvals. Previously, it was only for the deficient MMR mismatch repair pathway. For immunotherapy, now we have tumor mutation burden, high tumors, RET fusions, BRAF fusions, NTEP fusions finding their way in organ agnostic approval. Even now in pipeline, we know that NRG1 inhibitors are finding their role in multiple solid tumors, or FGFR is growing beyond the bladder and cholangios to find its utility in multiple organs, and similarly the HER2 targeted therapies. So essentially what is important,
Dasha, you have been muted.
okay, sorry about that. So essentially, it is important to look at the cancers beyond conventional histopathological subtypes and really categorize the patient based on the molecular alteration to have the highest probability of them responding. So this is about the utility, and which has been already discussed in detail by all our esteemed faculties. But when we are choosing a test, there are important perspectives which need to be kept in mind before we order our assay. So commonly we tend to ask, how big is the panel? How many genes are you analyzing? But more important question is, how good is the panel that we are prescribing? Is it really looking at the somatic or germline alterations, which will have different utilities based on the cancer type or the outcome that we desire? Whether it is only DNA hotspot or it also looks at the RNA fusions, whether it is exome or it is a targeted panel. We are fascinated by these larger panels like exome or whole genome, but they are really of research utility right now. The depth of analysis really gets impacted, and thus the sensitivity of the assay gets impacted if we are looking only at the exome and there is no targeted profiling that is being done. So it is important to exactly know what we are really prescribing for each of our patients. The type of biospecimen that we are referring for testing, whether it is tissue, whether it is enough tumor content, of course, the laboratory has to ensure that if they generate a report, that they should really check for the tumor content before they proceed with the analysis. And it is also important to choose the assay wisely, because if we do a cascade testing of limited genes or limited 12 gene panels is initially for a lung cancer, and if the tissue gets really used up, then we are not able to have a tumor mutation burden when we may actually need it for future treatment planning. So it is important to do the genomic analysis rightly to begin with. And the assays also are important in the sense that many assays may require DNA analysis to be done separately, RNA fusion analysis, so extraction has to be done separately, and that may impact when the tissue is really a very small biopsy or really very scanty tissue is available. Now we have ever increasing role of even tumor mutational signatures coming up, and that also is going to impact. So assay which can give us information upfront on SNVs, CNVs, the fusions, the TMBs, the MSIs, and the mutational signatures are really what we should be looking at to begin with, without compromising the sensitivity and the specificity. A bioinformatics analysis of the assay also plays an important role, because the classification of the variants, the theranostic relevance of that particular variant really needs to be precisely pinpointed before the clinician, the report really goes out to the clinician who is going to act on the information that you are providing. This is about, my slide is stuck. Yeah, sorry. So as I mentioned, it's important to not only look at the breadth of the coverage, but it is also very important to look at the depth of the coverage. There are certain assays which really do not give you the necessary depth, thus limiting the limit of detection, and you may miss when there actually is a actionable alteration, and we might be thinking that the tumor has no driver and may be treating them empirically. So this is all about the conventional comprehensive genomics. So what exactly is beyond the comprehensive NGS? Dr. Lima has very nicely elaborated on the role of gene expression, but I will still present a data from the WINDER trial, which really set the trend of gene expression in and its utility in solid organ malignancies, where the arm B, which was the patients were treated only on gene expression, did have a significant response in terms of the complete or partial responses or stabilization of disease, almost comparable to the DNA arm. The most important aspect here to be focused is that this arm B gene expression, these patients were those who did not have any actionable alteration in their DNA or the conventional genomic profiling. So this gene expression has utility in providing or expanding the role of actionable alterations when the tumors may really lack the conventional mutations or copy number or fusions. And the takeaway points from the WINDER trial were that transcriptome information can really help to navigate the path when we have no match therapy on the conventional NGS, and they are useful. Combining the DNA and the gene expression analysis of fusions are important to expand the scope of the personalization of treatment. So Exacta really looks at the tumor at a very in a very comprehensive way. It looks at the DNA mutations, copy number, the TMB, microsatellite instability, but it goes much beyond that. It also looks at the gene expression of all the coding genes, which is more than 20,000 genes, to look at the cell cycle pathway alterations and to find a second layer of information which we can utilize in our refractory or advanced solid organ malignancy patients. We also parallelly look at the germline mutations, because we know there is it's not only the BRCA1, BRCA2, there is other genes also which are playing significant role either in selection of PARP inhibitors, and that's why that germline analysis is also incorporated. The unique another unique aspect of the Exacta is the chemosensitivity analysis, and we also incorporate pharmacogenetics, like for example DPYD, UGT1-AMN analysis, to wisely put together the combinations after we have done the Exacta analysis for each patient. So this is what we do, but whether it is really effective, to demonstrate that, we undertook resilient trial in which we had enrolled 126 patients with solid organ malignancies who had minimum 2 lines of prior therapies and were refractory, and thus were enrolled on a clinical trial with Exacta analysis. Even in that clinical setting, the response rates were great. We had overall response rate of close to 43%, disease stabilization close to 93% was achieved. Of course, we had the breast and colorectal cancers, but we also had refractory head and neck cancers and many rare malignancies like pancreatic or the sarcomas. Even though numbers were not significant not really great for these malignancies, but even such rare or difficult to treat malignancies were also part of this cohort in resilient. So this is the best response rate that we could achieve with the Exacta analysis. And as I mentioned, there were even kidney cancers or the esophageal-gastric tumors, neuroendocrine tumors, sarcomas, and pancreatic or ovarian malignancies included. This was the final outcome based on the Exacta-based regimens. So in Exacta, it is not only the combination of conventional therapies, how the treatment recommendation is put together also differs. The majority of the patients had one targeted agent at least, along with 1 or 2 cytotoxic agents. We also combined endocrine agents like, for example, biculotamide when we had androgen receptor overexpression in gene expression or ISC positivity. These were the common combinations which were utilized for in Exacta. So Dr. Lima already alluded that there are multiple trials which have been undertaken to demonstrate benefit of genomic profiling, and the response rates with resilient were better. But I will like to add one more important factor, that when we are referring to one-off trial or NCR MASH trial or Moscato trial, these trials enrich the patient population. They first did the genomic profiling, identified whether the patient is having HER2 amplification or has a particular fusion, and then enrolled the patients, and then they achieved such responses. Of course, they were in different indications, but still, in resilient trial, there was no patient enrichment. Any patient with solid organ malignancy, refractory cancer who was enrolled received recommendation of Exacta. There was no patient turned away because of lack of information or lack of recommendation. I think that is very relevant, because now a comprehensive genomic profiling is very commonly opted, and majority of the patients, how many patients do we really have with actionable alteration? I think it is varies with multiple malignancies. In lung, we have many, but if we put all solid organ malignancies together, it is not going to be beyond 10 to 20%. And in Exacta has this unique aspect to it, that we can the Exacta analysis can come up with recommendation in all kinds of tumors. This is just another subset analysis wherein the mTOR inhibitors were selected based on either gene expression analysis or the immunocytochemistry profiling, wherein the mTOR inhibitors in combination with various cytotoxic agents or endocrine agents derived, the patients did derive benefit with ORR of close to 57%. Similarly, we have published another data for VEGF inhibition based on Exacta analysis, wherein again the combination of immunohistochemistry, immunocytochemistry, gene expression, as well as DNA mutations and copy numbers played a role to arrive at a probable recommendation. And these patients, again with refractory solid tumors, did derive significant benefit. So I think with restriction of time, I will just brush through next few slides. So liquid biopsy or the tumor profiling we have already discussed, but liquid biopsy is also finding its way in another indication, that is early stage cancer patients or stage 2, for example, stage 2AB colon, where they have undergone complete resection, and we are debating on utilization of further systemic therapy. Liquid biopsy, with the help of minimal residual dissection, disease detection in peripheral blood post-surgery, can really come to our aid to select or to decide whether we should go for adjuvant chemo, or these certain subcohort of patients may do away with just surgery. So, and we have results from dynamic study where ctDNA guided recommendation reduce the utility of adjuvant chemotherapies, but the PFS or recurrence-free survival, not PFS, the recurrence-free survival was equivalent or slightly better in these cohorts. So with our cancer tract minimal residual disease detection, we profile the tissue, then identify unique mutations in patient's tumor, and then develop droplet digital PCR patient-specific assays, and with that we try to detect the presence of minimal residual disease in their blood, as well as profile the samples, blood sample, with even organ agnostic panel, so that if there is an issue of tumor heterogeneity or new clone being rising, that also should get detected. So it is not only the what I'm trying to say, it is not only the liquid biopsy, but how we are utilizing liquid biopsy is also finding a broader utilization or broader utility in clinical management. But at the same time, we have to be really mindful when we are reading a liquid biopsy report. For example, it gives us a really useful information with real-time monitoring or minimal residual disease testing. But at the same time, you have to be mindful that if there is a negative liquid biopsy, reflex tumor testing is warranted if we really want to profile the tumor properly. Along with these limitations of liquid biopsy, we should also be mindful of the CHIP mutations. Like KRAS mutation, we may find it actionable, but even mutations in KRAS can also be CHIP associated, and that is something we should be mindful. And it is important what kind of assay we are utilizing, whether it is validated, and we have to be mindful about even the germline variants based on the mutant allele frequency, whether the mutation we are looking at is probably of germline origin. Still, we should not be concluding that based solely on the liquid biopsy. We have to undertake a sequencing of germline DNA to conclude. With this, I think I will stop my presentation and take up any questions if there are any.
Thank you very much, Darshana, for this very good overview about the possibilities in genomics. Does the audience have question at the moment?
I have a point to make. So, great presentation, Darshana. I mean, a lot of the data I'm already privy to, but every time it's another step of learning. So one of the things that I find very challenging, even though now I've been doing exacta interpretation for the longest time, even I find it challenging. And we see that the patients who respond to exacta directed treatment, then at a time point will then lose a response. At that juncture, one is at a loss whether we should repeat the whole exacta analysis, because it's a very extensive analysis, it's a very expensive analysis. So how does one decide at that time? What is the time gap where some of the data from the previous exacta is acceptable and the next longitudinal sequencing or longitudinal analysis of that patient? How should one judge that? Because many times we reach out to you and we ask you, what should be done now? But could there be an easier way to do that?
So I would say the conventional DNA sequencing or the fusion analysis, which gives us information about the real drivers, that is something is not going to really change. So maybe if you could, and if you have already targeted those pathways, of course, we will expect a resistance, new acquired resistance mutation. So maybe a limited analysis from liquid for those targetable alterations should suffice. However, the chemosensitivity aspect and gene expression aspect, I would say that it is more volatile in terms of, or is more real time compared to the actionable drivers. So looking at the limited resistance mutation profiling through blood and maybe repeating the chemosensitivity and gene expression alone should suffice in case there is progression post-exacta.
Great, thanks. And one just a comment to Stefan. So just in the context of what Dr. Darshana presented, I would like to say we get a lot of hand holding, and that's the message. That's one message that I would convey, because across the board, we see reports of tests that were done, but not applied. So it's a joke at my center, and my entire team is attending. It's a joke at my center that other people do the test, we do the application, but that's true. Because people test and then people don't know how to interpret. And that's where I think a very in-depth collaborative approach is required. Without that, I don't think we will win this.
Even as a laboratory end person, I think I find it immensely satisfactory when I have discussions with Dr. Limay. We really discuss cases and then implement, because it's not just enough, I guess, to process the samples and churn out the report. If you really see that it's getting implemented, that's the maximum satisfaction I think I can expect.
Right. And it's a longitudinal association, actually. It's not a one-time, because the case has to be explained and then the next evolution of the case. So excellent. Thank you.
Maybe I have something to add to your initial question, Swanti. We are about now to publish a case from Germany over the course of 4 years, where we did 4 exactas in a young breast cancer patient. She finally died at the end. Nevertheless, she was already out of guideline treatments when we started. And she survived for another 4 years, and always when a progression basically appeared. And this was also one of my questions that I had to you before. We always looked, where is the clinical pressure at the moment? And this is why we opted sometimes for ascites, sometimes for the blood, sometimes for tissue. And well, we got a lot of interesting information out of this. really a lot of information. The question is really how to steer through all this information and to apply the right therapy in the right time. This is sometimes a challenge. Nevertheless, discussions bring us further, definitely. So I think we are at the end. Are there any questions, any comments, any criticism? If not, then I would wish everybody a good start in the day. I think already some people have started to work. I wish you a good evening, a good night, have a nice afternoon. And I'm really looking forward to meet some of you live, maybe the next time. And yeah, I wish you all a nice evening. Thank you very much for attending. And I think the last word, I will give it to Dr. Darshana, because she all organized this over here.
Thank you, Stefan. I would just like to appreciate all the faculties, Dr. Limay, Dr. Behel, Dr. Rohatki, Dr. Farzad, and Dr. Andy Gaya, as well as I would like to extend my thanks to all the attendees who have been patient. But I definitely feel they have derived much information and much knowledge through this by listening to these marvelous faculties. Thank you so much, Stefan, and thank you, everyone. Have a good night.
Stefan, thank you
so
for
much.
doing such a great job introducing all of us with the tongue twister names. Thank you.
Thank you. Thank you.
Bye.
Bye.